Victoria. Yeah, good evening and a warm welcome to all the respected doctors and faculty who have joined us from your, hectic routine and practice, and especially considering the season of monsoon. So thank you so much for being here. I am sure it's going to be a very enriching affair, and it's going to be a lot of interaction. There will be hand mics across, different tables. There are case studies. There are different interactive material, and we'll ensure that we'll have more of a two-way communication in this particular meeting. So, as you are aware, this is the obesity orientation program, and this is a series that we are looking at. I'm sure we'll have more discussions on that, but very briefly to say why we are here today is because we have the step-up obesity orientation, and different reasons why we are doing that. We know that obesity is something we needs more recognition as a disease, how to assess it and how to manage it, and more to come on that from the faculty. I'm not going to delve too much into that. But very briefly to inform you that this is the kickstart of the Step Up Obesity series, which will ultimately lead to a very comprehensive obesity masterclass, which we are soon bringing in India. So this is what the agenda looks like. I'm sure the agenda is kept across and you've received the invite. I'm not getting into the details now. We will introduce each speaker as and when we have the sessions. So I would like to also inform you, as mentioned already, there's going to be a lot of interaction. So we want everybody to kind of come up with your experiences, ask a lot of questions, because we have some of the best international and national faculty here. So here's your chance to kind of share your experience and get your doubts clarified. So to do the context setting from Novo Nordisk perspective, I would like to welcome Victoria. She is the Senior Director of the Obesity Business Unit in Novo Nordisk. And Victoria, please, over to you.
Thank you very much. And I'm going to continue because that's a very old picture of me. So, no, now I need to go forward. And so, warm welcome. Thank you, everybody, for coming tonight on a Sunday evening. Also, a very warm welcome to everybody online. We are streaming this session here in Mumbai, and we will be continuing with this step-up program in different cities across India, and in Mumbai here as the first one. I don't think I need to tell you how alarming the problem of obesity is in this country. That's why we're here today, to make a change, right? And look to see how we can change that picture for this country. And a lot of associations have defined obesity as a disease and as a chronic clinical condition. For example, the World Obesity Federation. Obesity is a chronic relapsing progressive disease process. But then when we look at what is said in India, the last time I checked on the National Health Portal, at least, it's the NPH considered it more as a condition than a disease. So there's a lot of advocacy work. There's a lot of progress that we still need to do, and that's why we very much welcome and are very proud that you're here today to also dedicate your time and your effort to making a change in obesity and its management for the patients. So as Syed was alluding to, this is only the first step of this program, and I hope you're interested to, get on this journey together with us. It's the orientation today where we have Professor Arya Sharma with us. He has flown in from Berlin. We will continue then with a master class. So it's all about, interest in obesity management, building your own obesity clinic or your obesity program. We also want to give you some hands-on practical tools to do that, whereas you will also get a mentor. So we want to build a mentorship program with you. You have a mentor meeting 1, a mentor meeting 2. Of course, it's also building on the relationship that you will have with a mentor to guide you through and check in together. And then we will gather the group again to do experience sharing. So how was that journey? So we are looking at a journey over the next couple of months, and we do hope that you will stick with us on that journey and we can progress together. Now, just on the obesity portfolio, we of course have some drugs that are available in certain markets today. We are very much working on that these will be available in India as soon as possible. But I want to highlight here that India is very important for us as well when it comes to the new pipeline development. So India has been part of the STEP program, Step 1, Step 2, Select, our CV outcomes trial, and also STEP-HFpEF. But also the next generation of anti-obesity medication, CagriSema, those are the redefined trials, and some of you are also, involved in these clinical trials. So this journey is only going to continue, not only with Novo Nordisk, but with a lot of players. So this field of obesity will change rapidly in the next couple of years. So thank you very much. And Syed, I call Syed back to just introduce Dr. Arya Sharma.
Thank you so much, Victoria, for very nicely, crisply sharing the Novo Nordisk commitment towards obesity, and especially it's a lot of focus on India. And now we would like to welcome our guest for today, Professor Arya Sharma. And I'm sure most of you would have heard about him. So many scientific articles, as you see there, 500 plus scientific articles. He has been the Professor Emeritus of Medicine and Past Chair in Obesity Research from the University of Alberta. He's done a lot of pioneering work for Obesity Canada, and he's brought about a lot of change in the global guidelines as well, and has been a leading voice, not just for Canada, but across the globe. And he has also received several awards, as you can see there. In 2019, the Master of Obesity Medicine Award, which is the highest distinction award from the American Board of Obesity Medicine. So we are privileged to have with us, and I'm sure it's going to be a lot of interaction, a lot of questions that are coming up, and we hope we don't tire you too much with a lot of questions. So welcome, and the stage is yours.
So thank you, Syed, for that very nice introduction. It's a pleasure to be here, and I can see some familiar faces here because I did have the pleasure of being, I think, in the same hotel about a year ago. So thank you for coming back. Also, greetings to the online viewers. I think it's going to be a very interesting session, and I look forward to sharing some of my experience with you, but I'm also looking forward to hearing your experiences, because I think we all are struggling with the same issues. Now, just a quick background to this table. It says, how do you become, or why do we even need an obesity specialist? I did not start as an obesity specialist. In fact, actually, nobody starts as an obesity specialist. In fact, my training was in nephrology, and for the first 10 or 15 years of my academic career, I was doing nephrology. I was looking after patients with chronic kidney disease, patients dialysis. We had a very large hypertension clinic, renal transplant program. But I became more and more interested in the issue of obesity, because I was also seeing that many of the patients that we were seeing in the nephrology clinic, hypertension clinic, were actually struggling with excess weight. And there is some involvement of the kidney in excess weight and in the hypertension there, and we can talk about that if you have questions. And then I started doing obesity medicine, and when I went into obesity medicine, I must say, looking back, that I was actually quite naive about this, because my initial idea was, yes, I will start focusing on obesity, but it will largely be about giving people dietary advice and motivating people to be more physically active, etc. Till I realized that actually, telling people with obesity to eat less is about as effective as telling someone with depression to cheer up. It just does not work in the long term, and that is not real treatment. And so over the last several years, we have been looking with envy at the bariatric surgeons, because for a long time the bariatric surgeons are the ones who have always been claiming, no, we are the only people who can actually manage obesity in the long term, because only we have the treatment that works. And as an internist, for a long time, part of my job was preparing people for surgery and looking after people who have had surgery, because there was nothing in medicine that I could actually do for those people. That is changing now. So these are my disclosures. This is a growing list of companies. Currently, believe it or not, there is more than 45 different companies that have molecules that are currently in clinical trials for the treatment of obesity. So this is going to become a very, very busy space, and we are just starting on that journey. So in terms of why be an obesity specialist, I think the reasons are quite clear. There is no doubt whether the government thinks it's a disease or not, doesn't matter. For the patient, once you have a patient who has excess weight and that excess weight is causing health problems, that's a disease. Anything that needs medical treatment, medical attention is a disease. Currently, most people who have obesity, they are of course getting medical care, but that medical care is what I call palliative care. So, treating a diabetes in someone, you're not really treating the obesity which is causing the diabetes. No, you're treating the diabetes which is a consequence of obesity. So you're not really addressing the root cause of the problem, and you could probably see the same for a lot of the issues, the health issues. So you take a patient with fatty liver, you're treating the fatty liver, you're not treating the obesity which is causing the fatty liver. So, and the answer for that is we were not trained how to do that. We did not have the tools how to do that. We didn't have the treatments that we could offer that were effective. And so I think we can probably all agree that now that we are entering an era where we as non-surgeons actually are starting to have treatments that are effective for our patients, we have a lot of catching up to do in terms of learning. In fact, when I went on this journey, my personal journey of learning about obesity, I started by visiting the bariatric surgical clinics, and most of what I know about obesity management I have actually learned from the surgeons only. So yes, the surgeons have been a very big part of this, because all of the data that we have, reducing mortality, reducing cancer incidence, improving quality of life, all of that actually comes from the surgical literature, because in the non-surgical literature we have never been able to create that kind of weight loss and sustain it over long enough so that we can actually see any outcomes. And so I'm very happy that the bariatric surgeons are here today, because we will always be still learning from them, because they are the ones who have the most experience in managing these patients. So any comments on that? Anybody has any comment on any of these issues? Please feel free to speak. You can also interrupt me at any time if anybody wants to say anything. So let's start with why this is a disease. So the definition of disease, actually in Germany there's a very nice definition of a disease. And in Germany they use the definition that if you have a problem for which you have to go and see a doctor, you have a disease. It's a very simple definition. Okay? Any condition that requires you to see a doctor is a disease. Okay, and then of course we will say that obesity is a disease. Now you can also make other arguments. You can make arguments, well, it has so many comorbidities, it has so many complications, it's a complex etiology, all of that. But actually the answer is very simple. If your excess body weight or body fat is causing a health problem, you should go and see a doctor. That's the definition of disease. So now the question, of course, then becomes that most of us are actually not so much aware of this. And here's some data that actually shows this. This was the ACTION study, the ACTION India study. The ACTION program was a program that the company Novo did. They did in the whole world. There's an ACTION US, there's an ACTION Canada, there's an ACTION IO, and there's also an ACTION India, in which they asked people living with obesity, so PWO stands for people with obesity, and it asked them, what do you think is causing your weight gain? Now interestingly enough, the most answer is not I eat too much. The answer is always I'm not moving enough. And everybody believes that. We did a similar questionnaire amongst dietitians in Canada, and the dietitians also answered that the number one reason is people are not moving enough. When in fact actually not moving enough, although it is important, is not the main driver. By simply not moving, you're not going to start gaining weight. Okay, because actually your body weight will control its weight. It's exercising will actually help you work up an appetite. Okay, so when people start exercising, they actually start eating more very often, and so not much happens to their weight. Then they say it is unhealthy eating habits. When you ask them what is unhealthy, then also you get answers which you have to interpret very carefully. But I think the biggest issue here is that most of patients living with obesity ultimately believe it is their own fault. Maybe they have been told so many times it is their fault, so now they have started believing that. And most people, because it is possible in the short term to lose weight, anybody can lose weight. If I don't eat for a few weeks, of course I lose weight. That's not the issue. But because of that short-term effect that I can influence my weight, most people feel that I have control over my weight, when actually, in the long term, you don't. And we'll talk about that in a second. So the misconception that weight is something that I should be able to control and that I should have control over, and it is my responsibility to control my weight. That is the root cause not only of weight bias, weight discrimination, shame and blame and all of those things, but that is also the main reason why patients actually rarely go to doctors asking about help for their weight problems. And as a result, you can also see that the most common advice that patients get when they go to see a doctor is, I send you to the dietitian, I send you for some nutrition information. Prescription medications have so far not played a big role in obesity management. We can say largely because they have not been available, they have not been effective, and patients can't get them. A lot of patients, now we are seeing that even though these medications are now becoming available, a lot of patients say, no, I will try this without medication. They are very hesitant about medication, at least a lot of patients are. Some are not. Some are coming to your office and they say, doctor, please prescribe. But a lot of patients, when you mention medications or suggest that maybe they should try medications, there is still a lot of skepticism about that. And that is something that we are probably going to have to deal with. Okay. Why is obesity medical education? How many of you can say, and please use your sign yes or no, how many of you feel that when you think back to your medical training, medical school, residency training, postgraduate training, how many of you feel that you were actually given competent qualification information that that makes you competent to actually give advice to people with obesity? I'm seeing lots of no's here. Yeah, I wish you can see it. Okay, there's one yes over there. So sir, can you tell me what did you learn in medical school about how to treat obesity?
Not in medical school.
Not in medical school. Where did you?
After the medical school.
So where did you go for that training?
I did the SCOPE course.
Okay.
I did this Blackburn course from Harvard and attended few seminars at EASO and ASO.
So you're the expert. You should be here. So, and you have mentioned all those courses. There's the SCOPE course. In the US now, there's an American Board of Obesity Medicine exam that you can take. More than 7,000 people have taken that exam. You have to learn for the exam. It's not an easy exam. And then there is the SCOPE courses which are being offered by the World Obesity Federation. It's an online course. You have to attend the course, then you get a certificate. If you complete all the courses, also there is a small exam there. Obesity Canada is offering a certification course for people who have interest in this. And we are going to see more and more of those courses coming up. The Harvard course, that's a very nice one. The Blackburn course has been running many years. So there are resources that are now available for people who say, okay, I never learned in medical school. I have never actually learned how to do this, but there are many platforms now where the training is available if you think that you need it. And I can tell you that there will be even more training available. And as we have just heard, even here there's going to be the master class over the next few years. And you will be learning from folks like our colleague there who has taken all the courses, because there is a lot to learn. Right? There's a lot to learn about this because it's like learning how to manage diabetes, learning how to manage heart disease. You have to learn how to manage obesity. Okay, so now I just want to have you spend a few minutes at your table, just discussing or thinking about the following. What assumptions do you have about people with obesity? And what I want you to picture is you're sitting in your practice. Somebody comes in, they're maybe 70, 80 kilos. When you see this patient for the first time, you have no information about the patient. You don't even know why the patient is there. But when you see that patient for the first time, what are the kind of thoughts that go through your head instantly when you see this patient? Can we get a microphone? Yes. Please also introduce yourself. They may all know you. I don't know you. So please tell me who you are.
Dr. Acharya practicing at Dombivli, suburb of Bombay. When patient comes over here, we think that his diet, he must be eating more and not doing any exercise.
Okay. So instantly you look at the person and you're assuming probably he's eating too much and he's not exercising. Okay. Any other thoughts that come to mind when you see someone like that walk into your practice?
Yes. Sir, there may be some genetic predisposition or maybe some medical disease like hypothyroidism or something I have to think about.
Okay, so you think that there may be a medical problem in that patient also. Okay. Now I want to change the question slightly, and I want to change the question not what are you thinking about the patient, but what are you thinking about your own capabilities of being able to help this patient? Any comments on that? Yes, sir.
I want to help this patient to reduce his weight and the obesity related problems. That is my idea.
But do you ever feel helpless? Like saying that, actually I wish I could help him, but I know that I have very little to offer.
No, whatever I have, I will offer to him. Like advised exercise, advised diet. These are the two things.
Those are the things you can offer. How many of you, very honestly, actually get frustrated when somebody like that walks into your clinic and now you're looking at this person, he has got diabetes, sleep apnea, fatty liver, all the problems, and you're looking at the patient and you're saying, oh my God, what do I do with this guy? Can we get the microphone over here?
It does happen, sir. I mean, you do get, maybe not at the initial visit. Initial visit is too soon to really, because that's when you interact, you understand. But maybe a few consultations down the line, maybe 6 months, a year down the line, there are times when you're like, okay, now what do I offer? What do I do?
And how often do you get frustrated and actually if the patient decides not to come back, you have a sigh of relief?
So there's a statement in Hindi, Pran jaye par vachan na jaye. Sorry, vajan jaye par, how do you say? Pran jaye par vajan na jaye.
So I must admit, yes, please go ahead.
This is probably the entire audience apart from me are physicians and I'm the only surgeon here, so probably one of the questions would be that at the end of that frustration, how many of them refer the patient to a bariatric surgeon, I know 1 and 2 here for sure and 3 there.
So that depends on whether or not they were a diabetologist, because the diabetologist will never refer to the surgeon. Everybody else will refer to the surgeon, but not the diabetologist.
There are 2 sitting in the audience who refer to me.
I have never understood why, but okay, so already you can see in the discussion that there is sensitivity emotional. So the patient is also ashamed, is coming, is frustrated, doesn't know what to do, is looking for help. We are frustrated because we are not able to provide the kind of help and we are not seeing the success in our patients, except of course the surgeon. Everybody else is frustrated. So this was not a very happy place for a lot of physicians. And then also sometimes we feel helpless, right? We look at the patient is telling us, no, they're not eating so much, they are trying to exercise, they're losing weight. In fact, they have lost weight many times, every time the weight comes back. Now you're telling them to lose weight again. They say, what is this? I'm just keep doing the same thing all over the place. And so it leads to a lot of frustration. And I can tell you that for the first years where I was doing obesity medicine, I also was feeling very frustrated that I'm not able to help my patients because I'm not able to give them the treatment that they need. So we've had the sharing of the reflections. Now, as a result of all of the shame and the blame and the fact that obesity is visible, and if I lose weight, people can see it. If I put on weight, people can see it. In fact, what I've learned in India is one of the first, when you greet somebody, you say, oh, you put on weight. Or you say, before you even say namaskar or you talk about anything else, you're saying, oh, you have lost weight. So it has become part of sort of the culture to have this focus on weight, which also implies that this is something that is in the responsibility. If you have gained weight, you must have done something to gain weight. If you have lost weight, you must have done something to lose weight. One is positive, the other one is negative. So you can see how that happens. And there is a lot of literature on that people get teased about their weight, they get bullied about their weight, they get ostracized about their weight, they feel ashamed about their weight. And that takes us to something that has now been recognized, which is actually very important. This is the vicious cycle of internalized weight bias. And the way that this works is, person gained weight. Now there's many, many reasons why people gain weight. This could be all kinds of things. This could be, it could be a mental health issue, anxiety issue. It could be lack of sleep. It could be stress levels. It could be so many things. Pregnancies, whatever. They gain weight. Then they get the health consequences. Then they go to see their doctor. Then the doctor tells them you have to lose weight. Then they ask, how can I lose weight? Then they say, you have to eat less and you move more. They say, I'm already eating less, I'm already moving more, I have already lost weight, but still I'm putting the weight back on. So then the doctor says, no, you have to try harder. Then they say, well, why would I go to that doctor? Because what is he going to tell me? He's going to tell me to lose weight, I already know that. What advice is he going to give me? To eat less and move more? I'm already doing that. So then they stop going to the doctor, because now this becomes an embarrassing situation. They have negative feelings about themselves. As a result, because of the negative feelings, that actually we have learned that negative feelings about yourself actually drive self-harming behavior, and that makes the problem worse. So when people are not feeling positive about themselves and about their bodies, then they actually start doing things that it's like self-sabotaging themselves, right? So the results become even less, and then the weight goes up, and then you keep going in the cycle, right? And so actually, the negative feelings that patients are having about themselves are often one of the biggest barriers, and you have to interrupt that cycle. And the way that you interrupt that cycle is explaining to the patient that this is not something that is not a fault question. It is not a shame question. We have to look at what is causing the problem, and then we have to try to address that problem. And whatever we do to address this problem, there is not going to be an easy solution. And most likely, this is going to be a problem that you're going to be dealing with for the rest of your life. And I always tell patients, I've been doing this for 30 years, I've not cured a single patient. In fact, even our colleague, the bariatric surgeon, has not cured a single patient. He has helped patients lose weight and control their weight by doing the surgery, but all of those patients are still people living with obesity, even if their body mass, because if they go back to the surgeon and say, here, Dr. Surgeon, can you reverse my bypass? Guess what happens? The weight comes back. So they're not cured. They're only being treated. So we have to break the cycle, and the only way that we can break the cycle is by changing the way we approach these patients, how we talk to those patients, our attitude to those patients. I share with my patients that this is frustrating. I wish I had those medications. I wish I had a better treatment for you. I wish this was easy. I wish I could just give a prescription. For cholesterol I can do that. For diabetes I can do that. For hypertension I can do that. For obesity, it's going to be very difficult. Right? I tell the patient, and the patient, they're not happy, but at least it creates a conversation that is supportive. I say, I know we don't have good treatments, but we will try whatever it is, and we will do this together. So you need to talk about, you need to think about the language you're using, you need to think about how is the patient feeling. It may not be a happy message, but you know what, in medicine, very often we have to share things with patients which don't make them happy. I mean, you're giving a patient a cancer diagnosis is not making them happy. We know how to do that. We do it every day. Telling a patient that they have diabetes, or that they need hemodialysis, or that they have kidney failure, those are not happy messages. We have to tell our patients anyway, right? So it is not that we don't know how to give people unhappy messages, but in the context of obesity, very often I don't see my colleagues doing that, right? I mean, we're all pretending that there is a solution when actually there is no solution that is going to be easy. So we have to tell our patient that is the case. Okay. So I want to talk about the language. I want at least one of you to give me one positive example where you have seen that speaking to your patient in a supportive manner has helped change their attitude, maybe even your attitude and your practice. Just give me one example. Tell me one story. Anybody who has experienced this? Yes, please, sir. Yeah, the microphone is coming.
If someone comes with these kind of issues, say for example the weight is 120, and at the end of the day I just tell them, after whatever therapy we give them, you just tell them that look here, sumo people are 300 kgs, so you are just bacha in front of them.
Okay.
So then they get little positive feeling and they comply with your treatment. That is what I do.
Excellent. And your patients are, how do they respond to that?
So that's what I'm trying to tell you, that, okay, these people are, once you give these kind of examples, that there is someone who is even more obese than you and they are really healthy. And well, look here, then probably they feel that they have to do something.
Okay, excellent.
What I have seen is that we have a blood pressure cuff which is longer.
Yes.
And a lot of patients love that because very often they go to places where it doesn't fit them and they are embarrassed about it, and they're pretty happy that, doctor, you have a very, that's great of you, you know. So patients love that feeling that, you know, the cuff fits them.
Definitely. I mean, so this is a very important point, because if you are going to do an obesity clinic, you also have to make sure you have the equipment for those patients. See, if a patient is coming and is a big patient coming to obesity clinic and there is no chair that will fit them, then how can they feel welcome? Right? They say, what kind of clinic is the doctor even doesn't know that I need a bigger chair, right? So even the equipment that you have has to be suitable for treating this patient population. Yes, sir.
So then during the corona time, the assisted reproductive technology, that is infertility clinic, was banned.
Yes.
So we had a patient who was about 35 kilos extra with a sperm count of 4 million. And only by telling him to lose weight, in 6 months he lost about 25 kilos. Very dedicated guy. Count came up to normal and she conceived normally.
Okay. So that's a very positive message. Okay. How is she doing now? Did she put the weight back on?
Yeah, the husband has put on the weight back.
Okay, we'll talk about that. All right. So the do's and don'ts of delivering care, we are trying to promote healthy behaviors, but actually I'm not only trying to promote healthy behaviors in my patients with obesity, actually you try to promote healthy behaviors for everybody. Right? Healthy behavior is not a treatment for obesity, it is a treatment for everybody. It doesn't matter what the problem is, okay? You have to give patients specific things to do, and those things that you're asking them to do have to be realistic for that patient in that situation. So telling a patient, okay, you have to do 2 hours of exercise every day, but that person does not have time for 2 hours, how can they do it? Okay? If you're telling people that, you know, you have to get at least 7-8 hours of sleep, how can they get 7-8 hours of sleep if they have to get up at 4 in the morning to commute to their work, right? So whatever advice you give, it has to be realistic, it has to be doable for that patient. And you have to make sure, it says on the slide also, you have to have the appropriate blood pressure cuff, the gown, the seating, all that things. Asking people to take off their shoes when they cannot bend to put the shoes back on, very simple solution. You just have one of those long shoe horns so patients can put their shoes back on, right? Collecting a urine sample from someone who has obesity is not easy. Okay, so you have to have the equipment. There are solutions for all of this, but those solutions have to be available for those patients so that they don't get embarrassed, so they don't feel like, you know, I cannot do this, I'm being asked to do something that is going to make them feel worse or make them feel ashamed. Obviously, no fat jokes, no humor. It's not a funny situation. We don't make humor about people having cancer or people having heart disease, or this guy just had a stroke, let's have a laugh about that. No, it's not a laughing matter. Okay, so this is also not a laughing matter. So jokes about weight, jokes about size, jokes about appearance, we should avoid those. If we find our staff making those jokes, you have to talk to your staff. Okay? Don't automatically make assumptions about people's behaviors based on their size. Even don't make the assumption that somebody, when you see the person with 120 kilos, you should say, oh, you know, you should think about losing weight. Then the patient will tell you, you know, I used to be 150 kilos. I have had bariatric surgery. Actually, I am quite happy with my weight now. Now you're standing there like an idiot, right? Why? Because you didn't ask the question. Okay, so making assumptions about what people want and what they have done and what their past history is, you know, that is something that you should not give them advice before you have done the assessment. That is a basic rule. Okay? All right, lack of formal education. We have already talked about this. There are many resources now available. There are online, there are courses, there are classes, there are textbooks. All of that is now available. More of it will become available. And what is also important is that when you have positive experience, because you are the pioneers, you are the leaders in this field. By the fact that coming here this evening already has made you a leader. Because I hope that When you leave here, you already probably know more about obesity than most of your colleagues. So you're the leaders, and I think part of your job is going to be to share the information you get from here or from anywhere in obesity, share your experience with your colleagues, because most of your colleagues will not have the knowledge, even the most basic knowledge, about obesity and about obesity management. Okay, so any more comments about these recommendations? Is there something else that you think is important for your colleagues or for yourself that is going to help you be a better obesity doctor? Yes, please.
Use the patient first language.
Just please use the microphone so the online people can hear what you're saying.
Use the patient first language.
Use the patient first language, absolutely. Somebody else, any other comments? We have not heard from that table, so yes, please go ahead.
Now, what I have done is, and I found it work well, is I tell patients it's not your fault, the society has changed, the way we live today has changed, and I show them the real statistics across the world. Obesity is rising, so stop feeling guilty about yourself because the world has changed. That gives them a lot of hope and positivity. It's not their fault. When that guilt feeling goes, they get a lot of enthusiasm. And second thing which I found works very well is I talk to the spouse and the colleagues or the family members. When I talk to them, this gentleman is not to be criticized in the house. You need to understand that he's suffering. You know, suppose you had a person with a stroke, like you said, or you had a person with cancer, how would you react? So start reacting similarly. When he gets support from his family members and his close friends, I've seen a drastic change in the approach.
Absolutely. Thank you for that comment. Any other comments to this?
So we keep a small target for the patient. For example, if I tell the patient that you need to lose weight, so I tell them that you need to lose 1 kg per month. So probably that is doable. So at least, and I make them understand that, okay, even 1 kg loss would also help you a lot in your health conditions. So might as well do that. So that is very simple. So then the patients are also, a little motivated to lose weight.
Okay. Okay, I think.
I'd like to add here. I will first ask.
Who's speaking?
It's me.
Okay, there you go. Yes, please.
I will first tell the patient that whatever your weight is, first we stop gaining. That is the first target I will have.
Yes. Minimum target is you're not going to get weight. And that is what I tell many of my patients. I say, you know what? If this is your maximum weight, I cannot guarantee that you cannot lose weight, that you will lose weight. But we can work together that this will be the highest weight you will ever be. That we can do. For that I don't even need medication. Okay? And a lot of patients don't look at this, but when you see the definition of obesity, we're talking it's a progressive disease. Any progressive disease, if you can slow progression, already you're winning. Kidney disease, I'm a nephrologist. When somebody comes, creatinine is 200. If I can keep it at 200 or make it, or just slow the progression so that maybe they don't have dialysis in 5 years, they have dialysis in 10 years, I have done my job, right? I'm not restoring kidney function, but I have slowed the progression of the disease. And the first thing we can do in obesity is we can stop weight gain. By finding out what exactly is driving the weight gain, we have to address those root causes. Usually, and I say this again and again, I say overeating is not the cause of obesity. Overeating is the symptom of something going on in the life of that patient, which is causing them to overeat, which is then causing. So if I have to understand, if I think this patient is gaining weight because they're eating too much, that is like saying, oh, this guy has depression because he's not happy. But you're not explaining why that person has depression. No, you're describing what that person has. And similarly, when we say somebody is gaining weight because they're eating too much is the symptom of the disease, and we have to think what is causing that symptom. That may be lack of time, it may be lack of education, it may be some emotional issues, it may be some family pressures, it may be the culture, it may be the availability of food, maybe they're taking some medication that is making them hungry, maybe it is a genetic. Something is causing them to eat more than they need. What is the reason for that? That is the diagnosis. Okay?
Just a disclaimer, great discussions, but we are running late by 20 minutes, so
okay.
Probably, yeah.
So at this point, I think we are talking about the clinical assessment, and I'm going to make this very short because you have already heard all of this. The first one here is in the approach, traditional approach is body mass index. Now body mass index, what is body mass index? Body mass index is, we know how to calculate it, we use it, But what does it tell us? It tells us basically how big my patient is. It's a measurement of size. It is height and weight, right? So if you tell me somebody has high BMI, what do I know about the patient? I know he's big. Low BMI, I know they're small. That is the only information that is available to you from BMI. It does not tell you how much body fat. It doesn't tell you what type of body fat. It doesn't tell you where the body fat is located. It does not tell you whether this patient has hypertension or diabetes or heart disease or anything. It doesn't tell you anything, right? So BMI is a measure of size. It is not a measure of health. You can have two people, same BMI. One person has got sleep apnea, diabetes, reflux disease, plantar fasciitis, osteoarthritis. Next patient, same BMI, no problem. Normal triglycerides, no diabetes, no hypertension, nothing. So how can BMI help you make the diagnosis? Unfortunately, for now, we are still stuck with BMI as a diagnosis. We are working very hard, and there will be papers coming soon where we are moving away from the. If you read the Canadian guidelines for obesity, we are not using BMI for diagnosing obesity. We are using BMI for screening for obesity. It is a good screening tool, but it is not a good diagnostic tool. Okay. In India, we have an even more bigger problem, because here the correlation between BMI and the amount of body fat is even worse than everywhere else. Because here we have the people that we are now calling, and here's the famous paper. You know the paper. This is the paper from Anup Misra, who very nicely showed that the problem in the Indian population is that there are the fat, thin people. That even at what we would consider normal weight, already the percentage of body fat is higher than you would expect. And so the weight-related health problems that you're seeing, these patients start at a much lower body weight. And they can happen in people who, when you look at them, they say, this is not obesity, this is BMI 22, 23. But then you look at them and you take waist circumference, and there's 2 extra kilos of belly fat, already they have diabetes. So in India, we have the special problem that obesity actually starts very early, even in people who you do not think that, this guy, how are you saying he has obesity? Look at him, he's skinny. Then you look at him from the side and there's a small bulge. So, okay, that's obesity, okay? So that is a specific problem that we have in the Asian population. Now in Canada, we came up and we said, okay, if BMI is not giving us the information, then how do we get the information? So the information is very simple. We came up with a staging system in which we are staging the patient based on what is the problem that the patient has. So there's 3 dimensions of the problem. The patient can have a mental health problem, the patient can have a physical problem, the patient can have a functional problem. And we have shown in many publications now that it is actually the presence or absence of those problems which tells you about the prognosis of the patient. It's not how big the patient is that is the problem, it is how sick is the patient. And in order to know how sick the patient is, you have to do some tests and you have to look at the patient and you have to say what are the problems that the patient has. So in clinical practice, the way that we do it, I approach this from the back. When I see a patient first time, I ask myself, is this a patient who has end-stage obesity? So is this a patient who has so severe disease that even if he lost weight, probably it is not going to solve the problem, right? And then quickly, most of your patients are not stage 4. If he's not stage 4, then the next question is, okay, not stage 4, but does this patient have any clinical signs of end organ damage? What is end organ damage? That could be a myocardial infarct, that could be PAD, that could be diabetic retinopathy, nephropathy. I mean, those are all, it could be, fibrosis in the liver. Whatever the end organ damage is there, that is a stage 3 patient. If there's no end organ damage, maybe the patient has just newly diagnosed diabetes, no end organ damage, that would be a stage 2 patient. If the patient does not have anything like that, maybe they are pre-diabetes, maybe pre-hypertension, that would be stage 1. And if the patient has absolutely nothing, you can do all the tests you want and you don't find anything, just big patient. We call that stage 0 obesity. Why do we call it obesity? Just because if the BMI is in the obesity range, then we have to call it obesity, but I would say this is stage 0 obesity. You will find there is a small pocket card lying on your table where there is a quick description of the system. System is now actually getting more and more popular. There's now more than 80 publications using the system. And It has been adopted by many different guidelines of Canada, of course, but also other countries are now using this staging system. So let's just do a very quick example here. Just tell me, in this case, 32-year-old female, BMI is 32, hypertension, sleep apnea, depression. I want to know from you, what is the obesity class, what is the obesity stage, and how would you approach this patient? Let's get the answer here.
Obesity class 1, stage 2.
Okay, but this is obesity class 1 based on the Caucasian definition.
Yeah. Stage 2.
In the Indian definition, this will already be class 2.
Yeah.
Okay, and stage 2. Why did you say stage 2?
Already hypertension is there, sleep apnea is there.
That's it.
Depression is there.
There was no mention of end organ damage, so stage 2. So that is how you can use the system. It's very easy to use. Okay.
I wanted to ask one question.
Yes, please.
You mentioned obesity as a center, like so. About 30 BMI only will put in the staging, or below 30, because in India in between 25 and 30 there are lots of.
You can start staging with BMI 22.
So
see any patient where you think that this patient may have a problem because of excess weight.
You mentioned center as a obesity. So without obesity also you will put staging?
Well, you can start with overweight. So in this paper which I showed you just now, if you read the paper, actually we also found that even in people who have, you can say pre-obesity, BMI 25 to 30, Caucasian is pre-obesity or overweight, same issue. If that patient also has, has a myocardial infarction or has diabetes, the prognosis is the same. Okay, so we call this a complication-centric view of obesity and not a BMI-centric approach.
In India, we find lots of sarcopenic obesity. So have you considered that?
Yes. Okay, so I want to move into the panel discussion. So I'm going to bring up actually Saeed, who's going to explain this to us.
Thank you, Prof. So I think great discussions, and this mic is.
It's on.
Yeah. So now we have the interactive panel discussion, and I'd like to welcome the national faculty along with Professor Arya Sharma. So first of all, Dr. Rajiv Kovil sir, he's a founder consultant diabetologist at Dr. Kovil's Diabetes Center. I'm sure you know him very well, more than 2 decades of experience, and founder member of the United Diabetes Forum. And he's leading the project called ROAD, which is recognizing obesity as a disease in India. So yes, happy to have you, sir. And I would like to welcome Dr. Sheila ma'am. So I'm sure you all know her as well. She's a senior consultant endocrinologist at Saifi Hospital and Reliance Hospital, and she's been part of various clinical trials, rich experience both in terms of academics and trials as well, and has been the part of the scientific committee of some of the organizations, and she's also been part of some international guidelines, and probably looking forward to something on obesity, ma'am, as well going ahead, so we can surely collaborate on that. So kindly have your seats, please, and over to Professor Sharma to moderate the session.
Okay.
Rajiv, when we decided, since it's a session.
And we decided we're going to look straight, not sideways. We don't want to be diagnosed here on stage.
So my first question to you is actually, I think we can all agree that the complication-centric view of obesity is probably much more useful than just knowing somebody's BMI. Just knowing the BMI, I cannot make any clinical decisions. You tell me this person also has diabetes and sleep apnea, now I can make some decisions. So the question for both of you is actually, what do you see the challenges or other challenges in implementing a more complication-centric view of obesity in making the diagnosis and managing patients in India? Do you think it is easy, or do you think there will be some?
It's extremely difficult. As I told you that the greeting is about weight, and people don't consider that weight is the problem. The main consideration is that you have to accept that obesity is a medical disorder, which the US accepted more than a decade back. And here, as you said, that if you tell a patient that you have a problem, they'll say, doctor, I'll eat less, I'll exercise, and this should be over with. I don't need to discuss this with you. I came for my hypertension or my diabetes, so let's talk about that, let's talk about this. So obesity discussion doesn't start. Obesity as a disorder is not accepted, then the treatment is not going to. So we don't have traction for patients unless they are in this marriageable age group or infert patients, PCOS, who are highly motivated for getting benefit. Otherwise, people in my age groups and the ones younger to me usually do not approach us for this. So that's the problem. We are not getting that traction.
So Cheryl, let me ask you, when you try to explain to there's a newly diagnosed diabetes, comes to your clinic, you're making the diagnosis of diabetes. And if you, and the patient is asking you, so why am I having diabetes? And if you explain to the patient, okay, you are having diabetes because of your weight, how does your patient respond?
So if the patient is already diagnosed with diabetes and you tell them that it is because of the weight, the acceptance is pretty good.
Okay.
They do accept it. They do agree that yes, it is because of, it could be because of weight, apart from the other factors which cause diabetes. But at that point of time, the acceptance is pretty good.
Okay.
The problems which we face in our country, sir, are multifactorial, to be very honest. I mean, for example, even I would say both at the patient level as well as at the physician level. When you are talking about a patient, sir, and the Edmonton criteria at class 2 or class 3, it's pretty okay. We do not have that many problems. Of course, the conversation may be more in favor of talking about the disease at that point of time, as you rightly pointed out. But the problems, I personally feel that you need to address it much before, maybe in stage 0. And when you're talking in class stage 0 and stage 1, that's when the patient is not really willing to really address it very, very seriously. But I think the problem also arises, sir, because we also don't recognize obesity as a disease, really seriously. The patient, when they're obese, they will first approach the nutritionist. I mean, only when the nutritionist tells them that, okay, you're not losing weight, you need to get it yourself assessed, will they come to a medical doctor to understand, am I not losing weight because of some medical related problem. Most of our clinics are not equipped to deal with people living with obesity. I mean, we may not have, as you said, the chairs, we may not have the privacy. Taking a simple waist circumference, I mean, you very rightly said the BMI is not an accurate indicator, we all accept that. But for us, maybe a simple waist circumference can also be a challenge because of the clothing, because of cultural issues. I mean, we do not really, I mean, our patients don't wear a different garment when they are in our clinics. I mean, I'm sure people over here would agree with that. So, I mean, then maybe you need to use surrogate markers, you need a neck circumference, you could use a wrist circumference. We generally do not really do a hip circumference because, again, clothing issues are there. So even a diagnosis, a simple diagnosis of something so simple is difficult.
Challenging.
Is really challenging in the clinical world. And coming to that, I mean, different aspects of it. For example, our patients have a lot of resistance about medication. They still believe that allopathy is bad. The first concept is, as you said, we need to continue medicine. And the patients are like, ma'am, lifelong? No, I will think about something else. I think there's something else. Madam, they will try all the quackery in the world. And they will go to the dietitians, they will go to try everything so-called, I mean, alternative branches of medicine. But they will not simply take medicine, maybe for so many reasons that, we all know.
And we can discuss some of those reasons, and then I can tell you my solution to that issue.
If I could just add on to
ahead,
yes. I think there was an internal survey, I don't know whether it's Novo or Lilly's, where people with obesity in India, they first go to the dietitian, then to the gym guy, and doctors are third or fourth on the list.
Very true.
Some doctors are not even on the list.
Not even on the list.
Okay.
Unless we come on the list, it's never going to happen, never going to change.
Okay. So I think your chance now. Who of you, yes or no answer, please. Who of you thinks that with enough education and enough talking about it and education, in India also, people can start using, you and your colleagues can start using a more complication-centric view. Is that going to be possible, or yes or no? Okay, there's some maybes. Okay, so most of you think it is possible. And my experience also has been that when you explain this to doctors, it's not so difficult. It is not a difficult concept to understand that the patient who has more problems is the high risk patient, and those are the patients who probably need most attention. And unfortunately, BMI does not tell us who that patient is going to be.
But unfortunately, in India, I'm sorry to cut you, but doctors understand this. Patients don't, because people don't. They think that if you're overweight, then you are from a well-to-do family. You're eating well because you have more money and more disposable income. So unless they change and there is a change in their mindset, the footfalls won't come in.
So that is a cultural change, right? So as long as that is something that makes obesity quite difficult, but also quite interesting, because there's always a cultural context in which we have to deal with this problem.
Sir, if I can add something, yes, I believe this is possible. Because I believe education makes a difference. Every person whom we talk to, every doctor whom we talk to, finally it is going to percolate down. And actually we are doing it, but we are not really doing it categorically. I mean, a patient, obese patient, is if they complain about mechanical problems, you are somewhere in your mind putting, I mean, maybe you're not actually, I mean, sure, everybody in this audience is maybe not objectively.
Oh, you're not putting a number to it.
Yeah, you're not putting a number to it, but you are looking after it, you are treating it. The only aspect we really don't look at, I mean, maybe it's cultural, maybe, but we do not look at the mental aspects. We have a very big issue discussing, you know, any kind of mental issue in our society in general. And with people living with obesity, we still have a big problem discussing that, because as you said, the blame is on the patient. The patient cannot tell you, I'm depressed, I'm feeling low, because you're at fault. I mean, and we are not as, I mean, maybe it's a training, maybe we have not evolved sufficiently as physicians, but the fact remains that even our perception, I mean, we don't have, or maybe we just don't have the time. That could be another big factor. I mean, everybody over here, I'm sure, is dealing with 50, 60 patients a day, and nobody has a time to sort of, at the end of a long day, talk about mental health issues. So I think that aspect we are really missing out. The rest, I think the metabolic and the mechanical aspect is being dealt up, but without actually giving a number.
So this is a quick question maybe for the panel, maybe anybody wants to comment. So if you take the Edmonton obesity staging system and say, okay, let us take the system, it makes sense. Let us adapt it to the Indian situation. Let us call it Indian obesity staging system. What are the main changes that you think have to be made to the Edmonton staging system so that it becomes more acceptable in India? Let's go.
I think we should ask the audience, because I think we've gone through the EOSS, and I think India specific, as she said, that the mental health is something that people do not accept. The cultural issues which surround obesity and eating needs to be addressed there in the Indian scenario, and also that excessive greetings and excessive or exchange of high caloric food for every occasion is very much a culture in India. So those things need to be come in so patients can actually understand the problem, because I remember an article around a decade back where on one morning of Dasera, the city of Ahmedabad sold more than 40 crores of jalebi and fafda. You know, it was on Times of India headlines.
But thankfully that is only once a year.
So we have festivals throughout the year.
No. We have festivals almost at 200 days in a year.
Yes.
200 festivals a year. Then it becomes, and on the other 100 days there's a wedding.
There's a wedding.
So now what do you do?
These things, patients never understand these things.
I understand. Okay. Any other comments from the room, or Sheila, would you want to make a comment?
So I would like to adapt the EOSS algorithm a little more, maybe a little, in the sense, okay, I think in that algorithm, if you can also know about past weight loss, a little about, you know, their past history.
But let's remember what this is for. The goal of EOSS is so that you can identify the patients who have the highest risk, so that if you have to make the choice who gets what treatment. Now I know that here with any patient who pays for it, they will get the treatment. But when you're working in a system where somebody else is paying for the treatment, whether it's insurance company or whoever, and you also have to look at risk-benefit treatment. Every treatment, even the safest treatment, has potential risk, right? So when you do a risk-benefit calculation, say, okay, what is the risk of this treatment? What is the potential benefit of this treatment? That benefit will be much higher in a high EOS patient than a low EOS patient. Does that make sense?
Yes.
So the EOS is actually there to help you make a decision about how aggressively are you going to be managing obesity in this person, and what is going to be the likely benefit of treating. Because yes, I can treat all the stage 0 patients, but what is going to be the benefit? If there is a benefit, I will see the benefit maybe after 20 years. But when I treat obesity in a stage 3 patient, I will see the benefit in 1 week. Right? That is the difference. Yes, please.
So in my practice, and probably across the board in the country, all bariatric surgeons have already been using something like an EOSS to assess our patients, not just based on the BMI criteria. We are already staging the patients and defining how severe a risk they are with their medical comorbidities, and then deciding on the line of management. And today, with all the things that we have in our armamentarium, not just surgery, we are talking about bariatric surgery, we are talking about endoscopic interventions like ESG, like the balloon, like the swallowable pill, and now Ozempic and semaglutide. we are now able to better strategize on how to go about offering something to our patient to make that difference.
I mean, the basic rule is that low-risk patient gets low-risk treatment, high-risk patient can get a high-risk treatment, right? BMI does not tell you the risk, so how do you know the risk of the patient? Well, that is where the EOS comes in, okay? That is the purpose of EOS, okay? So I think, in the interest of time, we should move on to the next topic. Which, but no, you stay here.
Yeah, both the faculty.
Because we will now do the case discussion, so I'm going to hand over to one of you to moderate this one.
So ma'am, just one thing, so we have kept the cases across all the tables. So some tables we have case 1, some we have case 2, and some at the end we have case 3. And we request you, we'll probably give you 3 to 5 minutes. Please have a look at the cases. And maybe you can discuss among yourself, and we'll have a very interactive discussion on how you would like to approach the patient. So
just present the where are the cases? We have the cases on the slide now.
Yeah, they're on the slides.
They're going through it on.
So while they're going through it, let's.
Yes.
I think there's 3 different cases. Each people has a different case. Okay. So let's give them 5 minutes, then we ask them.
For the benefit of those who do not have this particular case study 1, it's up over here. Because there are different cases on different tables. So this study, this is the case 1, which we would discuss with the table which has case 1, with inputs from everybody else too.
Okay, who wants to go first? Who has case 1? Which table has got case 1?
First.
Yeah. Do you want to go first?
Can I
maybe
talk about the case a little for the
not able to see the case. If you want to take a seat or something, be better.
Now we move to the side. Yeah, good.
Till table 1 discusses the case. Just briefly, this is a 61-year-old gentleman who's come to the clinic primarily now. This is primarily has come to you for weight loss and both diabetes management. So this gentleman has come to you at this point of time saying that he wants weight loss and diabetes management. He had first visited, this was in 2021. He returned for follow-up after 2 to 3 times, and then, as often happens, this patient was lost to follow-up. At that time, he was weighing 95 kgs. I will not talk about the BMI because we said that BMI may not be a very accurate reflection. At that time, his glycemic control was poor, and he was prescribed insulin, canagliflozin, and metformin because the HbA1c was 9.1. Now in April 2024, he has returned. He has still a much more urgent need to lose weight because he's put on weight, and now he's still more worried because he's put on around 6 kgs with a BMI which has increased. So you saw him in 21, he's come back to you in 24 with further gain in weight on medications with insulin, cana, and metformin. These are his parameters. You have a patient with a weight of 101 kg, a waist circumference of 119 centimeters, BP 144/94, a percentage body fat of 36.8%, and these are his other parameters. So till the table decides the question, can I ask you one question?
Please.
I have the liberty. So the body composition analysis which we talk about, I just want to know, a lot of people are using it. I mean, what is the accuracy? Should we use it? I mean, we talk about body impedance. Your views?
We don't use it, right? We don't use it because we used to do it. We used to do DEXA scans on everybody, and then we show them the picture, and then we see this is the body composition. The patient, they like those pictures, or they get shocked by those pictures, and it looks nice. But we were finding in our clinic that we were really not using that information for any clinical decisions. So then we stopped doing it because it's also expensive. So patients like that. A lot of colleagues, they like it because they think it motivates the patient, etc. There's actually no evidence that it motivates the patient. We believe it motivates, but it has never been studied. And we also know that it is quite inaccurate. Even the best machines are not really that accurate. And it does not really change the advice that you would give a patient, right? Because most patients are going to have more body fat. And in India, there may be a slightly different situation because the body composition, especially at the lower BMI, that is where these machines may be useful. Because when you see a patient with BMI 21, you will say, no, this guy doesn't need obesity treatment. Then you find 36% body fat in someone with BMI 21, then you may say, okay, maybe we have to look at this again. Okay, so I think the body composition will be useful in the low BMI range, not in the obesity range. Because obesity range, anybody in the obesity range is going to have high body fat.
So even if you use it in the same patient subsequently over time, would it be helpful?
The reproducibility of these measurements is very iffy, right? Because so what is being measured? Impedance is being measured. Now, impedance basically is how is your body handling this, and that depends a lot on hydration, on body temperature, skin temperature. Your feet are sweating, you're going to get a different reading than if you have dry feet. Your bladder is full, you'll get a different reading than if your bladder is empty. You've just had a cup of coffee, that is going to change the impedance. So it's not a very reliable measurement, and that's why it's nice, you get nice pictures, you get nice numbers, but I would not rely on those numbers.
If I could add on to that, is that it's nice to onboard a patient.
Sure.
But later on, even when the patient works very hard, at the end of 6 months or a year and a half, it hardly moves.
Exactly.
The percentage body, and that is very demotivating. So probably onboarding, you may tell them that there's a lot of hidden fat, but later on, it hardly moves. So then it's very.
And it's not only demotivating. If you're getting a wrong reading on that day, right? The patient is doing well. They have actually lost 2 kilos, and then because I don't know, it is raining outside, or they just had a glass of water or whatever, they come and they get a reading which is now higher, which is a wrong reading. But that number will completely demotivate them, even though that number is wrong. But once you get the number, then how do you explain to the patient that no, this is a wrong number, ignore it, right? So I agree with you. Onboarding may be to motivate the patient, maybe to get a baseline, but getting on these machines every time the patient comes, those numbers are going to go up and down, and the changes are also going to be very minimal. Absolutely. That will make it very demotivating to the patient.
Yeah, it was very important for me to bring this across to the audience because it is being used very, very extensively at this point.
Because it's fancy.
Yeah, I mean everybody is using it, and that's the reason I wanted to talk about this.
No. They say it does because you have the one where you can hold the arms and stuff, but it's a very imprecise measure despite everything the companies will tell you.
The DEXA scan.
See, DEXA scan is more precise, but it is also more expensive and there is radiation. Okay, so we do not do body composition unless there is a specific question that we think we need to answer. So if you have a frail elderly patient who has got sarcopenia, for making that diagnosis, maybe we can use body composition. Although I personally think that having a functional test is much better for that. Having a hand grip test or something like that will give you much more information about whether that is a frail patient or not.
Will one all set?
Out of the box one, the skeletal muscle index, is it going to be different? How, it's very difficult to calculate that.
See, my personal opinion, and I've been on debates for this, is I do not care how much muscle you have. I care what can the muscle do. You look at a marathon runner, how much muscle do they have? They're running marathons, there's no muscle. So it is not how much muscle you have, it is what is the function ability of the muscle. And that neither the DEXA scan nor the body composition nor impedance, even the muscle biopsy will not tell you that, right? Ultimately, muscle should be evaluated not by its mass but by its function. And so instead of doing these type of tests, we should be doing functional tests on the patient. Can the patient stand up from the chair and can they walk 6 minutes? How fast can they walk 6 minutes? Those are much more important questions than saying this has 1 kilo more muscle or 1 kilo less muscle. Who cares? Right? So we should be assessing muscle function, not muscle mass.
So you have this patient, I think table 1 is getting restless because they want to answer all the questions. And now you have a patient who is the fasting 128, postprandial 257, HbA1c of 8.8%, triglycerides of 322, and this is the medical history this patient has. This patient, as we know, was on premixed insulins. 50/50 is available in our country. CANA, highest doses of SU metformin, hypertension since 14 years. A significant family history, no significant personal history. This is what the patient is telling you, that the weight gain in the last 10 years has been gradual. Lowest weight was 62 to 65 kg, so that's a real significant gain as far as the graph is concerned. Has never made any serious attempts at weight loss, has done some dietary restrictions, walks 4 kilometers per day. I'm sure sir is going to comment on that, on the walking part and how it really influences obesity, and has a screen time of 4 to 5 hours. Difficulty climbing stairs, shortness of breath, daytime drowsiness, some amount of OSA, which is reflected in the daytime drowsiness and snoring. So the questions for this patient, if you can also tell your names, that would be great for sir's benefit. Most of us know each other, but can we have a mic on that table? Who's going to be representing the table? Great, sir.
First of all, he's definitely obese, he's diabetic, and that's a vicious circle, you know. You have diabetes which is not controlled, you put them and he's not ready to comply. You usually put them on or add sulfonylurea, then add insulin, and insulin and sulfonylurea together will put on more weight, and then more frustration and mental issues, and the vicious cycle which sirs show us on this thing, it just continues.
So and which class of grade of obesity would he belong to, and which EOSS stage?
Him as 3, class 3. Looking at that.
From the size is class 3?
Yeah.
Class 2.
So 32 BMI, isn't it?
Achha, so class 2, stage 3.
He's stage 3, that's right. Yeah.
Okay.
Stage 3. So I would love to put him on GLP-1 and reduce his insulin and if possible sulfonylureas. That is what the first thing which I would love to do. Motivate. Most of these people, what in my practice what I've seen is that they have some kind of underlying psychiatric problem, and they consult on a side some psychiatrist, and they are on some antipsychotic drugs, some antidepressants, and usually they would not tell you, they would not come out and tell you that yes, I am on it, unless you interrogate the wife, spouse, or interrogate the family members, and they come out with that. Some of the patients, you will not get a history where they are taking some kind of alternative medicine, so they have a thyroid issue underlying for a long time, and then suddenly they come across some homeopath, some Ayurvedic physicians, and they say that okay, I don't want to take lifelong medicine, and sometimes on a sly they are taking some kind of steroids, and that steroid itself will put on weight, that steroid itself will sort of induce diabetes, secondary diabetes.
And how would you assess the impact of treatment during follow-up? What would you do, sir?
So initially regular follow-up every month, and then subsequently once they are stabilized, every quarterly. This is what I would.
So with this HbA1c, even if we add GLP-1 receptor agonists, would that be sufficient? I'll go back.
9.2. It was 9.2. I mean, you can. People vary, but you can, on average, you can get about a 2-point reduction, right? So it should be possible to bring into 7, around 7. Physical activity, he's already doing his, if that is true, his 4 kilometers a day. That's quite a lot. I mean, I was
worried.
I don't walk 4 kilometers a day, so this.
I would love to do 2D echo in this case because he is becoming little breathless.
So he's already doing something.
Cardiac evaluation, no, 2D echo.
My concern in this patient would also be the sleep apnea.
Yeah.
Because the sleep apnea symptoms, they mimic depression. Right? The patient has no energy, he cannot concentrate, he has no motivation, he's feeling tired and lethargic all the time. Those are actually the symptoms of sleep deprivation. And often these patients get misdiagnosed as having depression, and then they get put on antidepressants. What they actually need is a CPAP machine. Right? So I would pay a lot of attention to seeing what is going on with the sleep apnea here.
How about a PFT in all these patients who are in stage 1, stage 2?
Yeah, the PFT doesn't, it depends on how big the patient is. I mean, some of these patients, they have restrictive, you will find this in women, that they actually have a restrictive reduction in volume just because you have to move a lot of weight to take a breath. And so these patients can get dyspneic very quickly. Now in these patients, if a patient has dyspnea, now he's a guy, but if this was a woman, you would definitely also be doing an echocardiography, see if he has HFpEF. This guy might also have HFpEF. But again, I would focus, at least in Canada, I would probably focus on getting control of the sleep apnea. Now for the first time, just ADA a few weeks ago, we had the first study showing that medical treatment for obesity, if you can achieve significant weight loss, you get significant improvement in sleep apnea. Right? So I think sleep apnea is something that we often don't take seriously enough, but it can actually be one of the reasons. Maybe even his initial weight gain might be because of his sleep apnea.
Fair enough.
Very true.
I think sleep apnea and a cardiac assessment would be the best way forward during follow-up.
How about thyroid function test?
You can do thyroid function test, but in my experience, thyroid function actually does not really cause, I think there's a big misconception that hypothyroidism causes obesity. No, you can find hypothyroidism in people who have obesity, but hypothyroidism itself, it causes slight weight gain. Usually what you're seeing is, if it is severe hypothyroidism where you're seeing myxedema, etc., myxedema is not fat, myxedema is fluid.
Sure.
Okay.
Asking for the history of stress level and previous any traumatic incidences, mental trauma.
That is a different question. That question in my clinic, of course, I will spend time taking his full history, full mental health history. I will be asking him about anxiety and his negative experiences. I want to know what is this guy working, what is going at home in his spouse, what is his relationship, what are his kids doing. I mean, I will try to get that information. Maybe not at the first visit, but those are all going to be important information.
So, before the advent of GLP-1, in your practice, you would have seen this person. Doesn't this amount to failure of intensive medical management of...
This guy I would have sent to my surgeon.
Exactly.
No question.
Yep.
Point well taken. We would have.
Huh? He's happy. He's happy. Our surgeons are always happy. I mean, our surgeons were the happiest surgeons. They were getting all our patients.
Which table has case 2? Okay, lovely. So if we can have 2 minutes, you can have a look at the case till I talk about the case to the rest of the audience, and then one of the representatives can then discuss it at the end. Is that fine?
Go ahead.
Perfect. So we have a 25-year medical student, progressive weight gain for 2 years. He's tried everything, lost maximum weight of 2 to 3 kgs. Now he's regained more weight and his current BMI is 37.2. Complains of occasional epigastric burning sensation on having spicy food. These are his parameters: a weight of 110, waist circumference 110, BMI 37.2, 144/94 blood pressure. I won't go into the percentage body fat now, we've already discussed that. And looking at his parameters, again he has some amount of dyslipidemia, triglyceride 257 and LDL of 120, and pre-diabetic also. So we have this very, very young boy, 25 years old, which I think we do see quite routinely now in our consultings, right? We are seeing patients coming to us at a much younger age group than what we were seeing a decade back, and that is the irony of the patients we are seeing at this point of time. And we also know that our patients progress from pre-diabetes to diabetes much more faster. This patient has no comorbidities and not on any regular medication at this point of time other than the occasional PPI. Mother has obesity with osteoarthritis, no significant personal history. He did try the GM diet, no success, sedentary lifestyle, loves his fast food and a high carb diet frequently. So now the questions to the table: which grade of obesity, which EOSS stage, what would you really advise this patient, and how would you assess the impact of treatment during follow-up visits? Anybody? Yes, please.
I think I'll put him in a class 2 obesity according to BMI more than 35. EOSS, I'll put at the stage 2. He has already got a hypertension. And here I would say that this person is a medical student. He has lost weight. And then again, I think there is a he considered as a failure. There must be some stress and all, maybe stress of the study. If you'll see all the parameter, he fits in a metabolic syndrome. Is pre-diabetic, his triglyceride is high, HDL is low, LDL is high, so and overweight, obesity already. So I think, although he's a medical student, but I think I'll educate him. First is a medical education, explain him what is wrong with him and all. What exactly is doing wrong is one is sedentary lifestyle. Second thing, he has tried a diet, which is I think GM diet. GM diet is only temporary for a week and all. He must have lost some weight and all, and then he stopped and again regained weight, and he thought it is a failure. So we'll have to tell him that we have to go systematically and slow and all. He must understand about the diet and all. He has to stop having fast food, low calorie diet, at the same time carbohydrate restrictions, and sedentary lifestyle has to stop, physical activity has to start, and some exercise schedule also I'll give. I think initially we must try this thing, lifestyle changes, medical education, diet, exercise, and then see like what is.
Thanks for that, Rajiv. You are being a medical student in our country. How much is this possible?
I was actually going back in time.
Yeah, that's why I'm asking you.
My old days in medical school. My thoughts were that wouldn't you consider bariatric? He's a young guy, he's loaded, pre-diabetes, hypertension, dyslipidemia, BMI of 38. He's enjoying his fast food on Swiggy and Zomato. Unless you put a restriction on that, I think the longer solution would be obviously go in for lifestyle and probably anti-obesity medicine. But at this age groups, most people are rebellious, and I was one. So
ask me.
What about this genetic component where the mother is obese, and he has put on the weight? What is genetic component? Don't you consider this?
So well, I mean, what we can. I mean, obviously he has.
What would be your treatment for this guy?
What would your
if he's paying out of pocket?
Okay, if he's paying out of pocket and he has access to GLP-1s, I would probably recommend a GLP-1. Right? There's no question. I mean, today almost everybody I would recommend a GLP-1. Should be in the. Everybody should be on it. This is after, and for this patient.
But sir, would this guy continue GLP-1 for the next 40 years of his life?
That is a different question. We will see how he responds. We will see how he tolerates. If he has diabetes, you would have no doubt. You would say you would continue him on GLP-1 for the rest of his life.
Absolutely.
So why not for obesity? Like, I mean, it's the same medication. It's the same risk. It is the same harm. So, pardon me? So that is another issue. So, but that may be a consequence also of his eating habits, etc. This is definitely a patient where I would also, whatever else I do, I would definitely do an assessment. Clearly he's going to have high stress levels. He's probably not sleeping enough. He's probably skipping his meals. He's probably learning till late in the night, or he's out partying with his friends. Something's going on. These are all lifestyle circumstances that can be changed. Now, can they be realistically changed in his situation? That's a different question. But we will definitely assess those things. His eating habits, this guy will probably benefit from keeping some kind of a food diary, whether he does it on his app or he does it, however he does it. Self-monitoring is probably going to help this guy. Even if he does it for 1 month, probably he will realize that yes, there are a few things that he can change.
Sir, what about the type of food, veg or non-veg?
I don't care. The food is food. Okay, so all the studies that have been done with all the different diets.
No, in nature, if you observe, all vegetarian animals, they are fat. And non-veg, they are thin, like lions and tigers and everything. If you see elephant,
yeah,
the most important part, which way?
No, the elephant is vegetarian, right?
Vegetarian, yes, it's vegetarian.
So the dietary composition. I mean,
dietary composition is very important.
We can talk about that forever. I think you can be on a healthy vegetarian diet. You can be on a healthy non-vegetarian diet.
We have to take into consideration type of food, veg or non-veg.
That we could possibly discuss after because of time constraints.
We will discuss that while we are eating the non-vegetarian.
While having dinner, we can decide veg or non-veg. I have to finish one more patient.
Would you consider meal replacement? Maybe partial or full replacement?
Goal setting is
goal setting. Yeah, see, goal setting is important, but see, I never set weight goals. The goals I set are behavioral goals, because here's the philosophy of goals. Goals has to be something you can do. Weight is not what you're doing. What you see, what you can do is, I can tell this guy to have breakfast. He's not having breakfast, you have breakfast. Now that is a goal that he can. I say at least 4 times a week, 4 days a week, at least you should have breakfast. That is a goal that he can do. Is that going to change his weight? Maybe yes, maybe no. Right? So, losing weight is not a behavior. The behavior is what you do. And when we talk about behavioral goals, the goals has to be something you can do and not something that happens. right? And so any goal that you set with this patient, whether it is eating more fruits and vegetables, getting more sleep, doing a yoga class, doing 1 hour of meditation every day, whatever it is, it has to be something he can do, and that is your goal. Okay, when we talk about SMART goals, we are not talking about weight goals, we are talking about behavioral goals.
So he's having fast
a very
food.
important message, behavior goals. I think that's one of
He's
the
having
important
fast food, sir. So instead of that, we can have some meal replacement we can provide him.
So meal replacements would work for this guy. I'm a big fan of meal replacement, not as total meal replacements,
sure,
but as using meal replacements for foods where he doesn't have time to eat, because replacing a meal is better than skipping a meal, right? And those meal replacement, but then we have to be careful. What is the meal replacement? The meal replacement has to be an actually meal replacement, not like a protein bar or something which is just a there's all kinds of stuff on the market. There is a technical definition of what is a meal replacement. A meal replacement has to be 1/3 of everything you need nutrition wise in that. Otherwise it is not a meal replacement. Otherwise it is just a protein shake or protein drink or something. So meal replacements, the big advantage is I can carry them in my pocket. And when it is time to eat, I don't have time to eat because I'm busy. Then I drink my meal replacement or I eat my bar and I've had my meal and I can continue. So it is a very practical way of getting people who don't have time to eat regularly and don't have time to do things to still be able to manage their diets.
So I would still, Rajiv,
So a question that in some parts of the world, some MNC nutrition have come up with things which go with Ozempic. It's
the Ozempic burger.
Yes, Ozempic. And meal replacement also which sound like them. So is there an ideal meal? Because if this guy is not on a GLP-1, the meal replacement will not, but the GLP-1 plus a meal replacement. But is there an ideal meal replacement you can have for?
See, the meal replacement, there's, like I said, you're only allowed to call it a meal replacement if you can actually use it to replace a meal. That means that this meal replacement has to meet at least 1/3 of everything. So we're talking about 1/3 of the protein requirements, all the vitamin requirements, mineral requirements, all of that has to be in there. Then only it is a meal replacement.
Fair enough.
But the metformin is fine. Like, keep him on metformin. Metformin is not going to give him weight loss.
This patient is having some GI upset, which is mentioned here. So is it?
Yeah.
In the interest of time, I'm so sorry for being a bad moderator.
I don't think we'll get to
I think I need to move ahead because sir has to take one more lecture. So which table is doing study 3?
This is the fun stuff.
Sorry?
I said this is the fun stuff actually. In the case
I'm getting dirty looks from Novo.
Yeah, I know.
Yeah. So, okay. Which is table case 3? No table is owning up.
Nope.
Oh my God.
No, case 3 went home.
Case 3, no table is owning up. Okay.
Yeah, there behind.
There, the back is case 3.
Oh, thank you, sir. So till you all discuss case 3, I'll also, 45-year-old HR professional comes to the clinic, routine checkup for type 2 diabetes, weight gain since the start of insulin therapy 6 years ago. 14 kg she has gained weight since the start of insulin therapy, has been trying weight loss. She lost some, she's been yo-yoing and regained it quite quickly. Couldn't use SGLT2 inhibitors because of genitourinary infections. Tried doula for a year, did not see any weight loss benefits. Is not willing to go to our friendly bariatric surgeon. So we have a patient who's having these parameters over here. A weight of 98 kgs, a waist circumference of 108 with a total cholesterol 152, again significant hypertriglyceridemia. An HbA1c mind you of 10.4, which is significantly high. So we have an HbA1c of 10.4 in an obese lady who is on insulin at this point of time, 10 years diabetic, hypothyroid, just postmenopausal, recently attained menopause, past history of GDM also. Current treatment is IDEG as 24 morning, 24 night, metformin she's taking 2.5 grams per day, gliclazide 160 milligram per day, Sita and Voglibose. I've already said that she can't tolerate SGLT2 inhibitors. Strong family history, nothing significant, sedentary activity, portion size control, she does have an issue. If I can quickly have these answers before we go for the final words to Rajiv and sir. Please, sir.
Yeah. This appears to be class 2 and stage 2 or stage 3. It will be stage 2.
So would you say stage 2 or stage 3 diabetic?
Stage 2.
Stage 2.
And from the treatment point of view, I think she has tried everything, and most of our armamentarium is now this is empty. So the only thing is remaining is the bariatric surgery, I feel.
The bariatrics are very popular. He's going to be very happy tonight.
He's got 2 patients out of 3. That's
Yes.
a fantastic strike rate.
Sir, other than the bariatric surgery,
She does not tolerate GLP. Dulaglutide, I think.
dulaglutide she did, and she didn't see weight loss benefit. So in a patient who did not see weight loss benefit,
First of all,
dula.
yeah, dula does not cause a lot of weight loss, right? So the studies on dula show that you get maybe 2-3 kilos weight loss. So if you're going to use the GLP-1 for this, then you should use the GLP-1 which has, which gives you 10-15% weight loss, right? So so that would not be enough for me. I think that, if you're not going to send them for surgery, then you have to find some way of reducing the insulin dose. Where she's getting a lot of insulin, it's not working. She's in the cycle of continuous. So I want to know, what is her history of hypoglycemia? Is she afraid of hypoglycemia? She's also premenopausal. So now this patient I would also assess for depression. I would like to see what is going on at home, what is the situation. So this is a complex patient.
And how would you assess impact of treatment, Rajiv?
Obviously,
what would you do at follow-up?
I would put the patient on basal plus a GLP-1 on the background of metformin. Emphasize on lifestyle. And that GDM diagnosis 15 years back, that is like a metabolic stress test. Unfortunately, we don't have that structured care here, where that patient we could have prevented her from blowing up into a diabetic maybe 5-7 years, and that's what we see. 5 to 7 years post GDM, the patient actually gets lost following pregnancy. 5-7 years later, they come back with severe hyperglycemia. So that is a structure I think we should improve. And now the patient is also perimenopausal here. So I think weight loss needs to be very much there, and for that
it's going to be difficult.
It's going to be difficult.
Perimenopausal, it's going to be difficult.
Difficult, and that's why I said probably if we had injectable semaglutide or a higher dose of dulaglutide, the 3 or 4.5 may help her.
The protection of her hormones is also going to reduce. So cardiovascular assessment is also going to become mandatory at subsequent follow-up of this patient. So there are going to be a lot of more issues which crop up during subsequent follow-up.
That's what the cardiac study follow-up of 20 years said. They all develop some amount of heart disease over a period of time. So GDM is actually something that we need to chase once the
very aggressively. I think in the interest of time, I'm going to call it a day over here. Give the mic back to sir to take it from here. Thank you very much, sir. Thanks, Rajiv.
Thank you, sir. I'll take the point. Okay, thank you very much for that. So you can see in the master classes and in the mentorship program, you will have much more opportunity to be discussing cases. And you can see these cases are not easy cases. These are everyday cases, but they're not easy. And now that we are having, for the first time, effective obesity treatments, the question is, how do we integrate them into the care? When do you start the obesity medications? How do you manage the obesity medication? Who is the best patient for those? And how do we actually start using these medications in practice? Because they will become available. Okay, I want to move up to the next topic, where we now come to the exciting part of it. This was also, for me, this was already exciting. Now it's getting more exciting, because now we are talking about what is the future. And the future of obesity medicine is going to be that we are going to have extremely effective medications that are mostly well tolerated, medications with which we have already have experience, because these medications have already been around for quite a few years, and we have been using them for treating diabetes, etc. Now they're getting the indication for obesity, and these medications are going to become available. And I think I'll show you the data in a second. There is no question that these medications create clinically relevant weight loss, no question. The big question is, okay, so the patient is losing weight, but what else is improving? So now the focus, even in the outcomes of obesity studies, is going to be more and more complication centric. So the question is, so yeah, I can reduce weight by 15 kilos, but is that going to save lives? Is that going to reduce hypertension? Is that going to reduce fatty liver disease? Those are going to be the questions, and that is going to make this a really interesting field. So open house. my first question I want to get back to is why would you even consider a medication? And this is an important question because most people say, why do I need medication? I just go on a diet. I do intermittent fasting. I can do a keto diet. I lose weight. So why do I need medication? So how do you explain to a patient or to anybody or even to yourself or to your colleagues, why do we even need medication? Yes, please. Okay, and why do you think medication helps with the long-term weight loss?
If you use this anti-obesity medicine, because there is no other method which can maintain long-term weight loss. If you use this medicine, there is a weight loss and which is almost permanent or long-term.
So why is it? Yes, please. Metabolic correction. Why is it so difficult? So why do all the patients who are losing weight, except a few exceptions, 90% of patients, 95% of patients who lose weight, any method, they can have gastric balloon, they can have diet, they can have intermittent fasting, they can do whatever they want, they lose weight. 95% of those people within 2 or 3 years will be back at where they started. Why does that happen? Yeah, but so the brain remains the same, but what part of the brain is responsible for regulating body weight?
There are
hedonic theory.
So there are hormones in the brain,
yes,
which try to actually adjust this metabolic rate.
Yeah.
And once you lose the weight, they will increase the ghrelin and other components, which will again gain the weight. It's basically a central nervous system problem.
Exactly. So there is a homeostatic center in the brain whose job is to defend you from weight loss.
Yes.
That is the job of the homeostatic system. The homeostatic system has evolved to protect you from weight loss. Why? Because weight loss has never been a good thing. When people are losing weight, it is because either there is a stress situation, they are sick, there is no food, there is a famine, they have to, they're doing a huge amount of exercise because they're immigrating or they're running from something. So losing weight has never been a good thing.
Body loves fat.
Yeah, but that is not a good thing. It is good to have fat because I'm eating the pizza today, in 5 years I can still use same calories, it's already there. So actually having fat is a good thing, but if there's no famine, if there's no other problem, then it becomes something that is a problem. So we have actually a system which is there, which is the homeostatic system, that is there to defend us against weight loss. How does it defend us from weight loss? When I go into negative energy balance, it doesn't matter how I do it. I can do it with intermittent fasting, keto diet, or have a gastric balloon, fast, hunger strike, doesn't matter. When I go into negative energy balance, the homeostatic system will see the negative energy balance and it will counter-regulate. That is why it is a homeostatic system. That is what homeostatic systems do. They will counter-regulate. How does the homeostatic system counter-regulate? By increasing appetite and by decreasing metabolic rate. So basically my own biology is sabotaging all the efforts that I'm putting into trying to lose weight. And these are very powerful systems. The homeostatic system is actually very powerful. Even in the patient with bariatric surgery, how many patients have lost weight till one day they disappear? No, nobody. His patients disappear, they don't come back. No, that's not what I meant. I meant that the patient keeps losing weight till...
Statistically, you see that the follow-up keeps dropping.
No, I understand that. That's not what I meant. I said, how much weight does the patient lose after bariatric surgery? They don't keep losing weight till one day they're gone. No. They plateau at some point. Yeah. No, I understand. So even with that method, there will always be the weight loss plateau. What is the weight loss plateau? The weight loss plateau is the homeostatic system. It is defending your body weight. How is it defending your body weight? It is increasing your appetite and it is decreasing your metabolic weight. That sets you up for weight regain. So weight regain after weight loss is what I expect. Okay, it is the same way if I put a patient who has a drop in body temperature because they've gone into some ice lake or something, I take them out, of course the body temperature comes back. That is a homeostatic system. Someone who has a hypotension, someone who has hypoglycemia, the body responds and tries to restore. Body weight exactly the same. Okay, so patients are not failing because they're not motivated and they're not trying. No, they are failing because Their body, actually the biology is ensuring that they fail. The job of the biology is to make sure they fail. So why are the surgeons having success? Because they are actually interfering with that biology. No, for as long as the surgery works. Okay? And so educating the patient, motivating the patient, all of that is not going to change the biology of the homeostatic system. So that is the main reason why all the lifestyle interventions, etc., even if the most motivated patient, still the homeostatic system is going to sabotage that patient. So the reason that we are actually using pharmacology is because the pharmacology is changing the biology of the homeostatic system. What do patients who have had bariatric surgery tell you? I'm less hungry. I can go the whole day without thinking of food. They have lost 20 kilos. Actually, if a normal person without bariatric surgery loses 20 kilos, I can guarantee you they're thinking of food. That's the only thing they're thinking about. Where's my next meal coming from? Right? But they're starving. That is a normal response to being in a caloric deficit. Okay? Bariatric persons, no, I eat small portions, I feel full. How can you feel full? You have lost 20 kilos. You should be eating 5 times the amount. No, a small amount, I'm full. That is because you have changed the biology of the homeostatic system. Now we know see, the surgeons didn't know what they were doing. They were cutting and they were reconnecting and they were taking stuff out and all that stuff. And they said, okay, if the guy's not losing, we make even tighter, we make even shorter. Now they know that is not why bariatric surgery works. Bariatric surgery works because it changes the satiety set point and the homeostatic system. Now we know how that works. Now we say, okay, we are the medical doctors. We can also do that. Now we can use those medical, now we can medically address the homeostatic system. That's why our patients have success. That is the rationale for using medication. So why do we now recommend that we do this? Well, first of all, these medications, they work. By the way, I just want to mention this. So we are talking about medication. Actually, what are these medications? They're not medication, they're hormones. Technically, this is not medication treatment, this is hormone treatment for obesity. I always explain to my patients, so all the patients that come, they want the natural product. I said, there's nothing more natural than this is a hormone. I'm only giving you what your gut is making. In fact, when you look at the molecular structure of semaglutide, the homology to human GLP-1 is amazing. There's only 3 amino acids have been changed, and then there is a small side chain. In fact, the homology between semaglutide and your own GLP-1, there is more homology than most of the insulins that we are using to human insulin. Okay? So it is a hormone therapy. And I think we have to remember that, and a lot of my patients, then they feel okay. I say, we are using hormones all the time. We use thyroid hormone, we use estrogens, we use cortisone, they're all hormones. This is also a hormone. Okay? And what does this hormone do? The hormone is fooling the homeostatic system into thinking that you have just had a large meal. So the patient is eating less. Why are they eating less? Because they feel, the brain is thinking, oh, he must have already eaten. If you have just had a large meal and you go to the buffet, how much are you going to eat? Right? And that is actually how these medications work, or how this hormone works. It is telling the brain, no, you have just had a large meal. So now a patient is happy. Right? And that is why they can tolerate the weight loss. What happens when I stop the medication? Suddenly the homeostatic system wakes up and says, what happened to my 20 kilos? Now I have to get the 20 kilos back. So now they get the hunger urge, and now they're eating back, and they get the cravings, and they get the, why? Because that is the homeostatic system did not notice that they had lost 20 kilos. But you stop the medication, it is like the homeostatic system now wakes up and suddenly realizes, oh, 20 kilos are missing. We have to replace them very quickly. But that is what homeostatic systems do. So when patients ask me, so doctor, how long do I have to take this medication? My answer, till you decide you want to put the weight back on. Then you can stop. because the minute you stop, you're going to be hungry and you're going to have to, because the body will do what the body does. So that is the rationale for using these medications. So now I know many of you have probably already have patients who have used these medications. Does anybody want to share their experience, maybe one patient, maybe some patient where you have seen something that maybe you were not expecting in terms of weight loss in your patients? Who has had experience using a GLP-1 in patient? Even your diabetic patients? Almost everybody. Okay. And what do your patients tell you?
Most of them, they have little negativity because of...
Let's have the microphone over here.
Most of the non-compliance is because of gastric upsetness, vomiting and nausea.
Absolutely. So let's talk about the side effects for a second. Actually, these are not side effects. These are actually the effects of the hormone. What does the hormone do? The hormone delays gastric emptying, and it creates a sense of satiety. If I delay gastric emptying and make you feel full, you're going to get nausea, you're going to get, right? So you have to use a very slow dose, and you have to slowly titrate the patient based on tolerance, right? So I start patients with very low dose, and if they complain, also you have to educate the patient. You have to tell the patient that when you start this medication, you will feel full. You may have some nausea, especially if you eat large meals. If you're going to eat the amount of food that you're eating before, I guarantee you 100% you will have nausea. If you're eating too fast, you're going to have nausea. Okay? So you have to inform the patient, and then most patients will tolerate. If they don't tolerate, they cannot tolerate this dose, reduce the dose. Start with even smaller dose, right? Over time, you will find that most patients, you will be able to get them to the dose that you want them to get, right? So this is a purely patient management. I have rarely met one patient who was impossible to tolerate. Even the smallest dose, they say, no, I cannot do this. Okay, those patients are very rare. So this is a patient management issue. Okay, so we have talked about the pharmacological options of weight gain. Everything except orlistat is central. Orlistat is the least effective. Why is it the least effective? It is not changing the homeostatic system. It is purely mechanical. Okay? All the effective medications, they have to work over here. They have to work on the hypothalamus. They have to work on the limbic system. Otherwise, you're not going to see the effect. Okay, so this is the slide about it is a GLP-1 analog. GLP is a hormone. So remember, when you use these medications, you're doing hormone treatment. Okay, you're basically substituting a hormone, or you're using a hormone. Okay, robust weight loss, 14, 15, 16, 17, 18% weight loss across all the trials. That is impressive, right? We have never seen anything like this. Surgeons have seen it, right? Nobody else has seen that kind of weight loss over 1 year trials, 2 years trials. Sustainability, 2 year trials. So a lot of patients, they say, no, doctor, you know, now I'm taking it for 1 year, it is no longer working. Have you heard that from patients? What do they mean when they say that? When the patient says it is no longer working, what they mean is I'm no longer losing weight. That's what the patient says. You know, initially it was working, I was losing weight, and now I'm still taking it. It's not working anymore because I'm not losing weight anymore. This is where you have to explain to the patient, no, it is still working. If you want to know if it is working or not, just stop it and see what happens. Right? Because the minute you stop it, the hunger will be there, the weight will come back, right? So this is working. This medication at this dose in this patient, this is the effect. Okay? If some patients, it starts increasing, I can tell you, I can almost guarantee you, that patient is probably not using the medication the way it should be. Maybe they themselves are reducing the dose, they're skipping the dose, they're trying to reduce the dose a little bit because they're trying to, maybe they're doing something, right? What we know, and I'll show you the results, even in the 4-year studies, there was no tachyphylaxis in the sense that if I keep using the medication, it will stop working after a while. No. As long as you take the medication, as long as you take this dose, it will work, okay? So any patient who tells you, no, I'm taking the medication, but I'm still gaining weight, my first question is, are they actually taking the medication as prescribed? Okay, because every study shows it. This is a study, randomized controlled trial, everybody loses weight, patients take the medication, patients get placebo, weight goes back. Also works in adolescents, which actually makes my pediatric colleagues very excited, because unfortunately for pediatric obesity, which is even worse than adult obesity, there is no treatment. You have an adolescent, 14-year-old, you have to treat obesity, it's almost hopeless. Okay, even adults is difficult, adolescents is even more difficult, because adolescents are more difficult. Any disease, you're managing type 1 diabetes in adolescents, more difficult, okay? So now there's a treatment, and we have seen in the teen study that the effect, even the long-term effect, is as much as in the adults. Safety profile exactly the same. Okay, so for anybody who's treating adolescents, now we have a treatment which is also going to be approved for adolescents and teenagers. Okay, safety profile I've already talked about. The safety profile is basically what you explained through this. Now initially when the medication came, there was all kinds of talk, right? There was thyroid stuff. The only suspicion where there may be a thyroid problem, maybe, because it has not been seen in humans, it is based on animal studies, maybe medullary thyroid cancer, which is the rarest form of thyroid cancer. Now there have been large meta-analyses that show actually there is no cancer risk for thyroid cancer. Similarly, there was also other issues. There was this whole idea about suicidal ideation. EMEA has looked at that, FDA has looked at it, they said no, forget it, there is no suicidal ideation. Yes, people with obesity are more likely to have suicidal ideation, but that is not a medical effect, right? Same thing came from the surgical literature also. Then there is the pancreatitis. The pancreatitis is a real problem, but it is also extremely rare. Okay, I've been doing this now for 10 years, I have not seen one pancreatitis. I'm sure some of you might have seen it, because if you do it often enough, you will see it. But it is not, first of all, it is rare. Secondly, if you tell the patient that the minute they start having any symptoms, gastrointestinal symptoms, especially over longer treatment, then you should check them with lipase, etc., and see what is going on, right? Everything else, nausea, diarrhea, vomiting, constipation, all that we can control. Okay, the retinal issue. So let's talk about the retinal issue. Retinal issue is the latest paper. So he's reading papers every day. You must have a lot of time. Because that paper was just published in JAMA Ophthalmology just last week only. The newspaper, the media loves this story, right? They're trying to find something negative to write about, because the more negative, the more circulation they get, okay? So maybe there's an issue, maybe there's no issue. All I can tell you, first of all, that paper, even in the paper, they say we don't know if there is a causal relationship. It is a pure association retrospective study from an eye clinic. So everybody who is going to that clinic already has an eye problem, that's why they go there. It is not your general population. It is amongst people going to see the eye doctor because probably some eye problem. That's where they found an association that some of those guys were taking a GLP-1. There was no information on BMI. There was no information on how long have they been taking the GLP-1. There was no information, even are they on the GLP-1 at the time when they are coming with the eye complaint. None of that information is in the paper. So I don't know what the paper means. All I can say, first of all, that type of ischemia is extremely rare. They also say it is less than 1 in 100,000 patients that you will see this. It could be diabetes, it could be associated with obesity, it could be associated with all kinds of problems. So I don't know what it means. Do you know what it means? So now let's see. Okay. So I know the companies and all, they are very concerned. So they go back and they check all their patients and all their records, and so we will find out. There has not been any signal, in any of the study populations. This is not shown up in any of the studies, and now there have been 25,000 people have been done in clinical trials. Nothing has been seen. So it's rare. Okay, let's talk about SELECT. One of the issues that we have had so far, if you say, does losing weight save lives? That question till today we have not been able to answer. The only information we have had for that maybe it saves lives, probably saves lives, is from the surgical literature. right? Because in the surgical literature, we know that when you look at all the long-term registry data, the SOS trial and all those trials, in all of those trials, cardiovascular risk goes down, cancer risk goes down, total mortality goes down, but they're not RCTs, right? Those are all registry trials. So till now, there is no data, there's no grade 1 level evidence from RCTs of obesity management showing that we can reduce cardiovascular endpoints. Okay, that we have not had those studies. This is the first study. It's not that people have not tried. They have tried. They tried the look ahead study. They were not able to say anything. Why? Because the weight difference at the end was only 2 kilos. So they don't see a difference. Then they tried locastrin. Locastrin, they got 4 kilogram weight loss. So that is probably not enough. Other studies have not been able to show this. Okay. So now for the first time we have the SELECT trial. The SELECT trial is a large trial, 17,000 people, including 500 people in India. And what is the main result? The main result is that over 4 years of treatment, you get 20% reduction in hard cardiovascular endpoints, stroke, heart attacks, death. For the first time, now we can say treating obesity, at least with this medication, will actually save lives. The most important aspect of the study, first of all, is the safety, because everybody has been concerned about safety. You remember all those other obesity medications we have had so far? Why were they removed from the market? Cardiovascular safety. First thing you can say is, well, there is no signal here that there is any cardio. And there has been some concern, because what GLP-1 agonists do is, blood pressure goes down, but heart rate often goes up by 2 or 3 beats a minute. Okay, so people are saying, well, if the heart rate is going up by 2 or 3 beats a minute, maybe it's not reducing cardiovascular risk. First of all, there is no cardiovascular risk. If anything, it's actually going down. In fact, it is going down as much as we are seeing in the diabetic patients. Now, the important point is, this is in people who have overweight and obesity, but no diabetes. Okay, so this is the first time in a non-diabetic population with obesity, you have actually been able to show that using an anti-obesity medication will reduce cardiovascular endpoints. So this is going to be a trial. This will be like the HOPE study. Who remembers the HOPE trial? Right? It is like a seminal trial. The first time that somebody can demonstrate this in an RCT, this is the first RCT that is demonstrating that. So why did it happen? Well, because all of the things happen that we know happen when you lose weight. Right? The blood pressure goes down, better glycemic control, the triglycerides go down. In this study, CRP goes down, which is probably a measure of chronic inflammation. So all those things happen. This is not a diabetes trial, but even though it is not a diabetes trial, nobody had diabetes, but there were people with pre-diabetes. You can see the complete normalization of glucose here. In the other group, actually it increases, right? So in summary, the reason that we are thinking about using medication is because in the same way that we use medication for hypertension, cholesterol, statins, diabetes, all those conditions we are using medication. Now, the rationale for using these medications in obesity is because we can actually change the biology of the homeostatic system, thereby allowing our patients to lose significant amount of weight without increase in appetite. They still get some decrease in metabolic rate, but the increase in appetite is not there, right? That's how they tolerate the weight loss. We have enough safety data. I'm quite happy with the safety data. Now people will say, oh yeah, Dr. Sharma, but what will happen in 40 years? I said, in 40 years, I'm gone. Whatever happens, happens. So that is my answer. And semaglutide till today is the only obesity medication that has been shown to reduce cardiovascular endpoints. Now I have not talked about HFpEF. There is also a study showing renal failure. There is also a study now showing PCOS. So there's all these studies are now coming. Osteoarthritis also they have shown. So all of those issues, one after the other, all the complications of obesity one after the other, the trials are being done. Some have already been published showing that the benefits of actually treating obesity goes far beyond just improving the well-being of the patient or making the patient feel better so they can go to a wedding and they can do whatever they do. But we are actually improving the health of our patients. And I think that this will be, when these medications become more available, more affordable, more widespread use, we are actually going to see a significant change in medical practice, because probably every second patient who comes into your clinic is probably a candidate for these medications. That is going to completely change our practice. Any? Oh, the centromere. I don't know. I don't think the centromere was studied here. That will be very interesting.
Yeah.
So, in the interest of time and in the interest of the fact that the food is outside, I will come to the end. Today was the orientation. The next step is going to be the master class. You will all get the opportunity. You will get the invitation. Then there will be a allocation to a mentor. You will work with the mentor in face-to-face meetings. You will be doing case discussions. You will have the opportunity of asking all the questions. These are highly qualified people who have been doing this for a while. And then finally, at the end, the expectation is that not only will you be able to integrate this knowledge in your own practice, but you will also be able to help disseminate this to all of our colleagues who now we think everybody has to be an obesity expert. Okay, you will be the first obesity experts, but your job is to make all your colleagues have at least a basic understanding of obesity, because I think this is going to be relevant. Anybody practicing medicine should have a basic understanding of obesity and how to manage it, and now I think we have the tools for managing. We will have more tools as we go along, and so this is going to be a very exciting era. It's a new chapter in medicine. I think this is more important than the introductions of statins. This is probably more important than the introduction of DPP-4s or the SGLT2s. This will have a bigger impact. Our ability to medically manage patients with obesity will have a bigger impact on our medical practice than anything else we have seen recently introduced into medicine. So we will see whether that happens. But right now, I think that is the way things are going.
On a lighter note, one of our patients was telling that if he is paying for so much for medicine, there is no money for food.
Okay, on that note, there is food outside. So, okay, over to you.
No, I just want to just quickly thank you. Thank you to the audience. Thank you to the online audience. We hope that you will come, to the masterclass and debate more with us on the cases. So thank you very much. Thank you very much to our faculty and hosting this excellent case discussion. And thank you to Dr. Arya Sharma.